Hi, my name is Madison Sheets. I'm a pharmacy student at the UT Tyler College of Pharmacy. Today I'm presenting a patient who came to our ER. She's a 54-year-old female named Vicki Pope who was admitted on 1/13/15. Her chief complaint was her fever. She was running a temperature over 101 degrees Fahrenheit for more than 48 hours. She was admitted and found to have cellulitis upon arrival as well, with drainage from her right groin that was an identified boil to her left gluteal area, which also had another boil. She presented with severe pain. She has no history of this present illness. Her past medical history does include ESRD. She's currently on hemodialysis 3 times a week. She is insulin dependent, type 2 diabetic. She has hypertension, hyperlipidemia, CHF, and she did have an echo a month ago with normal ejection fraction, but she did have stage 1 diastolic dysfunction, a stroke in 2012, prior NSTEMI, diabetic retinopathy, diabetic neuropathy, and then also a past history of asthma and depression. Her social history includes no acknowledgement of tobacco, any alcohol consumption, or illicit drug use. Her sister is also on hemodialysis, and then her surgical history includes a tubal ligation. Her 3 relevant drug allergies are ibuprofen, hydrochlorothiazide, and Bactrim. Her home medications you can read on the chart, but they are as follows: acetaminophen, insulin glargine, insulin lispro, clopidogrel, atorvastatin, aspirin 81 milligrams, albuterol, HFA, hydrocodone, and acetaminophen, PRN, ranitidine, amitriptyline, gabapentin, and metoprolol succinate, as well as sevelamer. Her immunization history was not recorded in her files. Her total body weight is 96 kgs and her ideal body weight is 65.9 kgs. Her vitals upon arrival include a blood pressure of 131/57, heart rate of 92 beats per minute, temperature of 101.8 degrees Fahrenheit, respiratory rate of 16, O2 98, and a pain scale of 9. She does have that right longitudinal region with a small 6mm pus draining point without any fluctuant fluid. Pertinent labs include a serum creatinine that is on the rise, trending upward. It is currently 7.16, and a calculated creatinine clearance of 9.6 milliliters per minute. She did have a blood sample that was drawn, and it has no growth that was identified. She currently has an anion, glucose, and white blood cell count all trending upward, and hemoglobin and sodium trending downward in her labs. She did have a chest x-ray and a CT of her abdomen and pelvis, and her inpatient medications are currently listed, but I'm just going to say the names of them as her dose, unit, route, frequency, and indication are all in her charts. So she's on vancomycin and Zosyn empirically for her cellulitis. She's also on Kxalate, normal saline, acetaminophen, sevelamer, insulin glargine, insulin lispro, gabapentin, docusate, darbepoetin alpha once weekly on Mondays, clopidogrel, calcitrol, atorvastatin, aspirin 81 milligrams, albuterol, HFA, hydrocodone, acetaminophen, PRN, heparin, and ranitidine. Her 5 problems that we've assessed in order of importance would be that sepsis, 202 to cellulitis. The patient did present to the ED with that fever, elevated serum lactate. She was tachycardic with elevated respiratory rate and elevated white blood cell count. The cellulitis without abscess is suspected, and that's indicative of sepsis, and she will need fluid resuscitation and empiric antimicrobial therapy, which she was put on Zosyn and vancomycin. Her ESRD is the second prioritized identifiable problem that she has. Patient is receiving hemodialysis Monday, Wednesday, Friday, typically for 3 hours. The patient did miss the last session due to infection and has an elevated BUN of 56 with that creatinine level of 7.16. Patient was also hyperkalemic due to her last missed dialysis session. Her CAD is the next identifiable problem. The patient did undergo surgery 2 weeks ago to have an RCA stent placed. That's something important because though she is on clopidogrel 75, aspirin 81, and metoprolol succinate 50 milligrams TID, Patient's therapy might not be optimized because according to the 2014 AHA-ACC guidelines for management of these patients that have had an NSTEMI with ACS and then also had a stent implantation, it might be more reasonable to use ticagrelor over clopidogrel for their P2R12 inhibitor therapy. That's to be discussed more in the plan. So her diabetes is currently uncontrolled. She was started on insulin glargine 35 units this morning upon arrival, and then also had a dose of her insulin as per using sliding scale. That blood glucose upon admission was 151 with persistent increase the following day to 335. So the blood glucose goal, as we know in the hospital setting, is between 140 and 180. Since it's not well controlled, she's at risk for micro and macro complications, so a slow titration upward for her basal and bolus regimen is recommended. We don't have any current HDL and LDL levels for her, so that's something that we should probably order. She is, according to AHA-ASA guidelines, on the correct regimen for that stroke that she had in 2012. That's her final prioritized complication that we identified, but that might contradict some therapy for her CAD, which includes that change in the Plavix. Plan includes for the sepsis, fluid resuscitation to initiate NS 30 milligrams per kilogram IV for the first 3 hours, monitor heart rate, blood pressure, arterial oxygen saturation, respiratory rate, temperature, urine output, and mean arterial pressure, and that empiric antimicrobial therapy of Zosyn 3.375 over 4 hours every 8 hours, and vancomycin 15 mg per kg loading dose with a 15 mg per kg maintenance dose with a target trough of 15 to 20 micrograms per milliliter. Also micafungin, 100 milligrams IV every day. For the ESRD, 15 grams of Kayexalate to treat her hyperkalemia as a one-time dose, and then continue taking calcitrol 0.5 micrograms by mouth daily, and sevelamer 800 milligrams by mouth 3 times daily. For her CAD, it is recommended to change that Plavix to ticagrelor 90 milligrams by mouth twice daily because of her non-STEMI and ACS status. For her diabetes, to try titrate the basal insulin to 40 units every morning and 7 units of insulin Humalog before each meal with SSI. Her history of CVAs, she is on all appropriate therapy, and it seems to be pretty well controlled, but she did have that stent put in, so we are going to stick by our recommendation to change the clopidogrel to ticagrelor possibly upon consultation with a physician. She doesn't have any other pertinent radiology that needs to be performed. We do need to make sure that we're taking those vanc trough levels, wound culture labs, so that we can wean off that empiric therapy and get on the right antimicrobial therapy for her. And then have serum uric acid, serum creatinine, triglycerides, HDL and LDL labs to come back. We do need to continue monitoring her blood glucose 5 times daily, and see if there are any symptoms of micro or macro neuropathic complications. Also for bruising, dyspnea, diarrhea, and rash, and continue to monitor those pertinent vitals, respiratory rate, O2, blood pressure, eyes and nose, and her temperature, and with a desired outcome of overall resolution of her sepsis. Thank you.